in ensuring that CMC had got the accreditation from the NABH, and ma'am has been a very, very open-minded, straightforward. I've always admired her from the way she speaks, the way she carries herself. She is going to be talking to us about occupational health services and accreditation, and I think she's the most apt person to speak on this topic. So shall we welcome Mrs. Lallu Joseph to give.
Very good afternoon to all of you. And thank you very much, Anita, for that introduction. I don't deserve a bit of that. I will start my session on occupational health and accreditation. I'm sure all of you here at some point would have gone through this process of accreditation. It's not anything new, but I thought I will link it to the background of what is happening in the other industries across the country. Now, we all know occupational health in India is nothing new. It started 50 years back with the legislation of the, the Factories Act in 1948. The regulatory authorities are very limited to about 1,400 safety officers, 1,154 inspectors, and 27 medical inspectors across the country. Now this, for a huge country like ours, it is grossly inadequate, even for the inspection of formal units which employ only about 10% of the labor force. Now, it is estimated that about, it's one of the leading causes of death in the country, underreported as well. Around ILO estimates about 4 lakh deaths in a year due to unsafe work practices in the country. But this again is not a very formal figure because as we all know, it gets underreported. We don't report most of the incidences that happen in the hospitals or anywhere, any industry as a matter of fact. Now, after the Bhopal gas tragedy, and many clauses have been added to the Factories Act subsequent to the Bhopal gas tragedy. Now, coming to the OHS regulations, I thought I'll just start with an overview and take you through the hospital setup. Now, OHS regulations, there are many, many laws governing them. And these are some of them. And yesterday, Dr. Sonawane spoke in detail about the radiological protection rules, which most of the hospitals follow because otherwise we have a show cause notice or suspension of, the usage of machines. So at least that we are following quite stringently. But otherwise, many of the rules, we have great difficulty in implementation. And the report, as I mentioned earlier, this is grossly inadequate for the implementation of most of the acts and rules that govern occupational related issues in the country. Now, this is just about 10% of the workforce that we talked about, where most of these acts and the rules apply to. What about the rest, 90% of the workforce? Now, when I put up some pictures, you will agree with me that this is a common scene that we see every day as we drive past. And most of our towns today don't have roads. If you drove from Katpadi to Bagayam, you will agree with me that there is a stretch of about 2 kilometers where we don't have road at all. It's on the mud road. How many of you experienced that? It's just mud, nothing else. I'm sure all of you would have experienced that. So this is nothing new. How many of you have seen this? I'm sure most of you, at least 90% would agree with me that you would have seen such a scene sometime, at least in the last 1 year, you would have definitely seen. What about this? How many agree with me that this is not happening? What about this? And what is this? This is very, very common to us. Most of the hospitals have problem, though we say our biomedical waste management is as per the rules, we don't follow. At least about 90%, I must say, I go as assessor to many hospitals, so I know exactly what happens in most of the places. For the sake of education, we impart training, but whatever said and done, end of the day, segregation is not appropriate. Even if we segregate, it is all taken in common bins, we don't know what happens after that. The outsourced agency, what they do with that, we don't know. So this is the scenario in the country at the moment. Now, we are an elite group. Healthcare services. At least we don't work on the roads. We don't get into the manholes. We are definitely an elite group, white-collared. So, are we there? Do we have problems? Definitely yes. Peter Drucker rightly says that healthcare organizations are the most complex organizations to manage, which is very true because it doesn't employ just one category of people trained to be, surgeons and physicians. Varied group, doctors, nurses, technicians, about 100 categories of technicians, housekeeping staff, people who push patients and move, administrative staff. So the groups come with varied background. They come from all possible background and then they get together. What happens with the mistake done by one person automatically affects 10 or 12 people around him. So that is the situation we are in. And running a hospital is in brain surgery, it is difficult. Being the wife of a neurosurgeon, I always hear that brain surgeries are the most complex, which you wouldn't agree. Probably the cardiothoracic surgeons would say the other way around. But whatever said and done, hospital administration is difficult than doing a brain surgery. I don't know if you'll agree with me with that, because it is a varied group with a lot of egos. Another side, you have plenty of problems to tackle, and that is the situation we are in. This is for patients. This is not for people who are working in the hospital. Healthcare is hazardous. Working in Kalpakkam Atomic Power Station is safer than working in Christian Medical College, Vellore, or probably even in Ramachandra. It is extremely hazardous. They compare the industry to bungee jumping, which means falling from top of a cliff. So you have a better probability of survival if you fall from height than getting admitted into any of the hospitals as a patient. So this is for the patient. Now, what about us? What about people like us who are working in the hospital? It is even more hazardous. Now, this is from the labor data, Bureau of Labor Statistics in the US, and they particularly point out that hospital setup is even more hazardous than working in a manufacturing industry. So we are all working in a hazardous environment, and all the more reason why this initiative of the occupational health team, putting the whole gamut of occupational health in hospital setup becomes very important at this point in time. With that, I must tell you, I'm extremely happy to talk in this forum, because this was a dream at one point in time. When we all started, we thought, a day should come when we really present what Christian Medical College has done with occupational health. And thanks to Dr. DJ Christopher and Dr. Alex for putting a beautiful team together. And I think we have reached a certain stage where we are able to happily project where we are at this point in time. Occupational health and safety management systems, like any other quality management system or safety management system, needs the commitment of the leadership. So the most important thing is the commitment of the leadership or the top management. In CMC, we have that in plenty. We have a lot of people, any issue, any problem, anything. There are so many volunteers, and they are the best in the field who come together and tell the administration this is needed, and the administration puts in their heart and soul into it. So the management and the leadership commitment is the prime thing for any occupational health and safety management system. What next? Unlike other management systems, occupational health systems require the participation of the employee. End of the day, whatever systems you put in place, if the employee is not following what is required, it doesn't make any sense. You have TLD badges. In CMC, we have more than 853 radiation workers. But it's so difficult, end of 3 months, to collect the TLD badges from all of them, or even to ensure that all of them actually wear the TLD badges appropriately. So This is exactly the problem because people don't realize, or the employees don't realize, the importance of doing things that are required to protect themselves. Now, you mandate things, but if he doesn't think it is important, how much can you mandate? We tell our housekeeping staff to wear rubber gloves because you may have a needle stick injury if the segregation is not appropriately done, but he doesn't think it is important. So during an inspection, you see him with the rubber gloves. The next day, he's walking around barefooted without any gloves at all, leave alone a rubber glove, he's not even wearing a latex glove. So such is the situation. So the most important thing next to the top management commitment is the employee participation. The third is identifying the hazards and the areas of vulnerability within the organization. I think that I'm just putting the perspective from the CMC side. We have done that hazard mapping. At least we know the kind of hazards that are involved in CSSD or a laundry or a ward. What are the various hazards? We have listed that out, and I think Dr. Alex also put it forward. Next is prevention and control. You provide them with safety gear, what is required, appropriate education and training provided, and you have to, as an employer, give them the needs to protect themselves. You can't expect a housekeeping staff to comply with what he is expected to do when you don't have adequate number of gloves in the ward. So you need to provide and have adequate prevention and control mechanisms in place. And another pillar of the whole thing is education and training. Constant education and training, not just one-time education and training, because we tend to forget. What we listen is just 5% captured. Then it's forgotten. So constant education and training is what is required. Finally, evaluation and improvement. Any system is dynamic only if it is audited periodically and improvement areas are identified, and it is a cycle. So the most important component in this whole thing is the employee participation, followed by education and training, and evaluation and improvement subsequently. So this is a continuous cycle, and it is not an ending cycle just finished with one-time education and training. There are many, many guidelines and standards available. OHSAS, which is how we call it, 18,001 standards, it applies to all industries. It is not specific to hospitals or any manufacturing industry. It applies to all industries, awarded after successful audit by an awarding institution. It is something like the ISO system, where there are experts who come in, audit, and see whether you comply with the OSHA's guidelines and give you the certification. It is not an accreditation, it is a certification. OSHA's project group, they submitted this 18,000 series in 1999, and it has two specifications, 18,001 and 18,002. 18,002 gives the implementation guidelines for 18,001. So there are more than 54,000 organizations that are certified by OSHA's, and as on today, the number is 63,000. So OSHA's is a good starting point if you are looking at where to start with the occupational health program in your own hospitals and organizations. Coming to the next one, ILO, OSH 2001 standards. ILO stands for the International Labour Organization, and they are the governing body, and they look very critically at the occupational health related issues across the globe, and they provide a lot of guidelines. Now this guideline that is published by ILO is for the member countries, and it is not mandatory, it is not prescriptive. It just gives the guidelines for the nation to evolve a policy on occupational health and safety, and institutions can adopt that and customize their occupational health and safety program in line with the ILO standards. So that is the second one, which is the guideline-based ILO OSH 2001. Then comes the ISO. ISO, as you all know, the International Standards Organization, is in the process of developing guidelines. Now, what they have done is they have taken the good points from all the other guidelines and accreditation standards, and they have put together, and they will most likely be putting forward the standards in the year 2016. But they stick to time frame. They have said October 2016. So therefore, October 2016, we will have standard guidelines and at least some pathway to follow if we are getting into into occupational health and safety accreditation. The most important thing that the hospitals are going through now is with regards to accreditation. It could be NABH, ISO, JCI accreditation. How many of you are from hospitals that are accredited by NABH, JCI here? Not many? We are accredited. CMC is accredited. Yes. Thank you. So I'm sure all of you would have come across this term of accreditation, NABH, JCI. Yes. It is proven that accreditation is the best possible tool for having quality and safety systems implemented. And it is a voluntary process. Initially, when we embarked on this journey in 2008, it was very much voluntary. But now, Tamil Nadu government has made it mandatory for NABH entry level at least for the Chief Minister's scheme, empanelment of the Chief Minister's insurance scheme. So we are full accredited. The main components of any accreditation is quality and safety. 50% weightage for quality and 50% weightage for safety. And one of the most important components is occupational health, staff and employee safety. When we talk about safety, it is not just patient safety, it is the employee, the staff, the outsourced staff, the contract staff, and anybody who gets into the hospital or the organization is covered. So therefore, this accreditation has a major component of occupational health and safety, and that is another way to get yourself organized or tuned to occupational health and safety. What are these standards or what are these accrediting bodies? It's not something new. They are not telling you this is how you have to perform, this is how you have to do things. Standards remind us of what we have forgotten to do. We all know how to write a medical report. All the doctors here will know how to give a discharge summary. But there are certain times when we fall or we tend to forget. So these standards are just reminders for us that we have forgotten certain things to do and just to wake us up. And that is exactly what our experience has been. It is not that some accreditation body has come and told us this is what you need to do. Lot of things we have been doing, but it's a consolidation of what we have been doing is what has happened after the exercise. Yesterday when Dr. Bobby spoke about the staff service, health service in St. John's Hospital, I mean, a similar setup exists in CMC. And I asked Dr. Henry today, do you remember when this SSHS was set up in CMC? And he says, I don't know. He's the head of SSHS. And this is probably from the days of Dr. Idaskada that it started. So it's always been there. Looking after the health and safety of the employees in CMC culture has always been there. And SSHS in a day sees about 900 patients, or rather staff, in, am I right, sir? Yes, 300 patients, yeah, in a day. So that is where we are. So it's not anything new, but it's the consolidation that has happened. Where did we start? In the year 2008, we had this urge to get into accreditation. And at that time, it was highly debated whether ISO or where are we going to get in. But anyway, we decided on NABH. And this is the first training program we all attended in 2008 by Dr. Vikram Kashyap and Dr. Murli, who are our alumnus, and they are both very renowned people in this field of neurosurgery and neurology. So they came and trained about 89 of us into internal assessment. And we worked very hard for 1.5 years, and we put forward our institution for pre-assessment to NABH. We didn't do any cosmetic, any makeup to the institution. We presented the institution as it is. We had a lot of problems. And this is exactly the signage that they captured the day one of the assessment. The first picture they captured was this, the fire exit. And nobody knew what this picture implied. So this is a traditional picture, and I always put this in any of the presentations that I talk for us, because this is an eye-opener. Fire exit, where do you run? And these are some of the pictures that were taken during the pre-assessment. Lot of safety issues, plenty of issues on loose wires, needles being, this is typically the picture that was taken on the day of assessment. Umpteen number of safety issues, safety, safety, safety. We are the institution largest in the country to be accredited by NABH, and by and large, we are the ones who had the maximum number of non-conformances, about 256 non-conformances, and we are very proud because we had so many non-conformances. Only after that we woke up. So that is exactly the situation with which we started. Then we realized we are talking quality, but there is a huge lacunae with safety because most of the non-conformances were safety-related non-conformances. And this was the picture taken on the day of assessment again. The box was there without any hose reel at all. So then the institution decided that we will have a separate group looking specifically on safety issues. So we have a quality, which has about 169 department quality managers at the moment, and we have a safety cell with about 180 department safety advisors. Now this was started at that time by our Associate Director Admin, Dr. John Muthusamy, headed the safety cell for some time, followed by Dr. DJ Christopher, and now it is Dr. Anil Kurvilla who's heading the safety cell. So it is under the Associate Director showing the commitment of the management to the safety of the employees, the patients, everybody. So when we started, we said these are the various components of safety in CMC. So we looked at the most important component, which we thought was most important, infrastructural safety. We put everything, and as one point, in the end, it was occupational health and safety. Only one component of this whole thing was occupational health and safety at that point in time. Rightly, we had a lot of training conducted and a lot of before and after pictures, like the obesity pictures. Now, things are in place, at least to the extent of about 70–80%. We have a lot of training programs, mock drill conducted. Everything goes on very, very smoothly now. At one point, we were more like jokers. When we started our mock drill, it was just the nurses in theater, and along with them, we did the audit. Now it happens like clockwork. We have the anesthetists, we have the surgeons, and it's a mela in theater when we have a mock drill, because samosa, coffee, everything is served. And it's wonderful now. So that is exactly where we are. But when we had the safety conference last year in 2014, it was more or less decided, because Dr. DJ Christopher, it is his probably a pet project, working very closely with TB. He said occupational health should be more prominent. It has to be, because employees, probably HR and, lot of involvement in occupational health and safety. So it was decided that we will, at some point in time, have a separate conference for occupational health and safety. If we have the whole team together, within 1 year, establish systems and protocols in place for occupational health and safety. And Dr. Reginald Alex and Sir took on the responsibility, and it has come out beautifully well with the dedication of almost 22–23 team members looking into various aspects which Dr. Alex projected. We have a wonderful occupational health team now. Now, why specifically on occupational health issues? Because most of the safety issues that were pointed out were also employee-related issues and occupational health-related issues. Of course, the biomedical waste segregation, a major issue in any hospital that we go to, and we also have been having repeated issues on biomedical waste segregation. Vaccination of staff. Sir will agree with me, the first dose is given, and then after that the boosters are, they don't come, because the first dose in CMC is given pre-employment, because otherwise the first salary doesn't go. So now it is made mandatory that the booster doses again are made mandatory. So therefore, probably the 4th month and the 3rd month and the 6th month salaries also don't go. I don't know if that is, it's ratified, I suppose. So now it will be compliant, because anything now has to go with the stick, no longer carrot all the time. So a lot of things have changed. Food handlers, the vaccination of the food handlers. We have more than 7 canteens operating in CMC, 7 operators. So to get them compliant with the policies of FSSAI and the vaccination, it is extremely difficult. So there are groups now looking into every aspect of this. Biosafety cabinets. At one time, we thought these are just boxes kept in chemo rooms. We didn't realize the importance of what these were doing. Only after some NC came in, we thought, okay, now let's look at these biosafety cabinets. The science behind it was amazing. We never knew it was class 1, class 2, class 3. Probably the oncologists knew. But none of the others knew that there is something called class 1, class 2, class 3 biosafety cabinets. And if it's an oncology setup, you need to use class 3. You need to validate the HEPA filters that are there. So that was a science by itself. So we learned a lot. And why all this? How to protect our nurses who are mixing the drugs. How to educate them. What to do in case of a chemo spill. A lot of things we have learned out of one NC that came. And PPE usage. It's just not there. Obviously, the nurses and doctors may be complying, or may not be complained, don't know. But lot of issues with PPE usage, lot of issues with other, they don't see the importance of using personal protective equipments. So that again was one major issue. Chemicals. I think we have really made a headway with chemicals. At that time, we didn't know how many chemicals were there existing in the hospital. So we did an audit, and we were shocked to see that we had stored about 1,000 chemicals in the hospital. So then we put a project. We had 6 people sitting on it and developing the SDS sheet for 1,000 chemicals. We have a 2,500-page document in the intranet on chemical safety. Rightly, Dr. Vijay Kumar took over, and now things are falling into shape. We have SDS sheet, at least for major chemicals, laboratory chemicals, and other things, and training is happening, spill kits are there, mercury is being weaned out. Now, as he said yesterday, 96% has been weaned out. It's only the rest, 4%, probably when the equipments get condemned, we will buy non-mercury based equipments. Hazard identification. We didn't know which area was hazardous. We didn't know the hazards involved in CSSD. We didn't know the hazards involved in any theater. So this was another major exercise that was undertaken. Anesthesia gas scavenging system. We only knew that the surgeons slept very early after a surgery, but we didn't know why that was happening. So therefore, we had to really get into the system and study the anesthesia gas scavenging system and see exactly the kind of escape of anesthetic gases. So a lot of things this team has done. They have put together a lot of consolidation in the area of occupational health and safety. This is the hazard identification HERA map, and it is finally a team. It is not an individual. Lot of teams in CMC now, quality, safety, occupational health, and merger of all these teams has brought about a lot of change in the institution. Now, I'm putting forward a small challenge in front of you. When I happened to see these pictures, this got circulated in the Facebook. Why men die fast? And these are some of the pictures that were circulated. Occupational hazards. Is it true that men die fast? Maybe it's time for all of us to sit down and do a study, Dr. Alex, and see. Okay, then it proves wrong. Thank you very much for the patient listening, and best wishes to all of you.
May I request Dr. Henry to come up on stage, please?